1, 2,
And review, female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's, charter book.
300 please.
I'll CPR again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what do the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
You know, usually when we talk about a medical diagnosis, there's this expectation of precision. It's almost like engineering.
Right. It's very binary, structural.
Exactly. Like you break your arm, you go to the ER, the X-ray shows that jagged white line through the radius, and the doctor just points at the screen and says, you know, there it is. That's the problem.
And that's comforting, honestly. We like things to be visible.
Totally. We like them to be categorized so we can just, you know, put a cast on it and move on.
But then you step into the world of neurocritical care.
Oh, man. Yeah. You step into intracranial regulation, traumatic brain injury, neuroinfections, and suddenly that metaphorical X-ray machine is just totally broken. Yeah. We're looking at a diagnostic landscape that is entirely murky.
It really is. The brain is basically this black box locked inside a rigid, unforgiving vault.
Right. And the terrifying part is that when things go wrong inside that vault, the signs are so incredibly subtle for hours or even days until they are suddenly just catastrophically obvious.
And by the time they are obvious, it's often too late to reverse the damage.
Right, which is exactly why we're doing this deep dive. Today, we are speaking directly to you, the dedicated ICU nurse looking to elevate your practice from just being competent at the bedside to truly thinking like an elite intensivist.
We're going to aggressively apply the 80-20 Pareto principle here.
Meaning we are going to extract that 20% of critical high-yield pathophysiology and clinical reasoning that dictates 80% of your bedside outcomes.
Exactly. We want to transform the foundational facts you learned in nursing school into immediate life-saving pattern recognition. Because in the ICU, your patient's brain cannot advocate for itself.
Right. The monitor might beep, but it doesn't give you the context. It relies entirely on your ability to translate a subtle sluggishness in a pupil or a slight shift in a pressure wave into action before the catastrophic signs ever appear.
So I am thrilled to be here to connect that cellular pathophysiology directly to your moment-by-moment nursing actions. You, the listener, are the critical third member of our rounding team today. We're going to go deep into the mechanics of a failing brain step by step.
Let's do it. I'm coming at this as a fellow lifelong learner, ready to ask the questions and sometimes get confused so we can really get to the bottom of this. Let's start with the absolute foundation, intracranial regulation and increased ICP.
Before we can fix a broken brain, we have to understand how a normal brain protects itself.
So if we look at the 80-20 of this, why does intracranial pressure, or ICP, matter so brutally much?
It matters for one very simple reason. Sustained pressure kills tissue. The skull is a closed box. Normal ICP is usually between 5 and 15 millimeters of mercury.
Okay, 5 to 15.
Right. A sustained ICP of greater than 20 millimeters of mercury will crush and kill brain tissue, period. Anyone with a new mass, bleeding, cellular swelling, or a backup of cerebrospinal fluid is at immediate risk.
Okay, so the must-know facts for this foundation. I always think of the Monro-Kellie Doctrine like a strictly packed suitcase.
I love that analogy.
Yeah, let's say you've packed it perfectly for a 2-week vacation. It is zipped tight. Inside this suitcase, you have exactly 3 things. You've got 78% brain tissue, 12% intravascular blood, and 10% cerebrospinal fluid, or CSF.
Right. And the suitcase has absolutely no give. It's hard plastic.
Exactly. So if you decide to add a new pair of shoes at the last minute, let's call that new blood from a hemorrhage or swelling from trauma. Something else inside that suitcase must be squeezed out, or the zipper breaks.
That is a perfect visualization.
Yeah.
And because the skull obviously has no zipper, the body desperately tries to compensate to make room for those new shoes. The first thing the brain does is displace the CSF.
It pushes it out.
Yeah, it shunts it down into the spinal subarachnoid space. It basically says, we don't need all this fluid right now. Get it out of here.
Which buys you some time, right?
A little bit of time. But if the swelling continues, the brain moves to its next trick. It collapses its own cerebral veins to push venous blood out of the skull.
But there has to be a limit to that.
There is a hard mathematical limit to that compensation. You can only squeeze so much CSF and venous blood out before there's nothing left to squeeze.
Okay, so let's trace this pathophysiology step by step. Let's say the trigger is a severe primary injury, like a traumatic car crash. The patient arrives in your ICU. That primary injury happens once. The initial impact is over.
Correct. You can't uncrash the car. The primary injury is done. What you, the ICU nurse, are managing is the secondary injury, the aftermath.
So the physiologic change here is tissue edema and blood accumulating. The compensation is displacing that CSF and venous blood.
But once that limit is reached, the decompensation phase hits. The ICP rises sharply. As the pressure climbs past 20, the ventricles and the small blood vessels inside the brain literally compress under the weight of the swelling.
Wait, if the blood vessels compress, then cerebral blood flow drops, right?
Exactly. Cerebral blood flow, or CBF, plummets. The brain tissue is now being starved of oxygen. It becomes hypoxic, and eventually the tissue begins to die. It becomes necrotic.
But here's where I get confused, or at least where the physiology feels like this tragic irony. When the body is starved of oxygen, its natural defense mechanism is to open up the blood vessels, right? Vasodilation. It's trying to bring more oxygen to the starving tissue.
Normally, yes. But in the brain, it is a lethal feedback loop. You've hit on the exact mechanism that kills these patients.
Oh, wow. Okay, walk me through it.
So, when brain tissue is starved of oxygen, normal aerobic metabolism fails. The cells switch to anaerobic metabolism, which produces a massive amount of lactic acid. At the same time, because blood flow is sluggish, carbon dioxide is accumulating in the brain.
And CO2 is a potent vasodilator.
The most potent. Both acidosis and hypercapnia tell the smooth muscle of the cerebral arteries to relax. The brain is basically gasping for air, screaming at the blood vessels, "Open up, we need more oxygen right now."
So the vessels dilate to bring in more arterial blood. But we just said the suitcase is already full. Opening the vessels means bringing more blood volume into a rigidly packed skull that has literally no room for it.
Precisely. The vasodilation brings in more volume, which takes up more space, which spikes the ICP even further. That higher pressure then crushes the vessels even more, which causes more hypoxia, which causes more CO2 buildup, which causes more vasodilation.
It is a vicious, inescapable cycle.
It is. If you don't intervene, the pressure will seek the only exit available in the human skull, which is downward.
Downward through the foramen magnum, the hole at the base of the skull where the spinal cord exits.
Yes. The brain tissue literally pushes down and herniates through that opening, crushing the brainstem on its way out. Once the brainstem is crushed, the respiratory and cardiac centers fail, and the patient dies.
Okay, so as the bedside nurse, our entire goal is to catch this feedback loop before the brain starts looking for the exit. Let's break down the assessment, because if we are looking for subtle signs, what does that actually look like in room 4?
The absolute earliest, most sensitive indicator of rising ICP is a change in the level of consciousness, or LOC.
But we aren't just talking about a patient suddenly falling into a coma, right?
No. A coma is a late sign. We are talking about incredibly subtle shifts. The patient who was chatting with you about their dog 2 hours ago now has a slight flattening of their affect.
Like they just don't care as much.
Right, they seem a bit indifferent. Maybe they're slightly restless, picking at their blankets. Or you ask them to state their name, and there's a 2 or 3 second delay before they answer. It's a slowing of processing speed.
That is so easy to write off as fatigue, especially in an ICU where alarms are ringing all night. You might just think, oh, they're tired.
Which is exactly why you have to be paranoid. Any unexplained drop in attention span or orientation is an ICP spike, until proven otherwise.
Wow. Okay, what about the classic signs? The ones that are a bit more obvious, but maybe not yet catastrophic.
The classic signs include unexpected vomiting, and the key word there is unexpected.
Meaning not preceded by nausea.
Right. It's often sudden and can be projectile. It happens because the pressure is directly stimulating the emetic center in the medulla. You also see morning headaches or nocturnal headaches that actually wake the patient up from sleep.
Wait, why specifically at night or in the morning?
Because when you lay flat, gravity is no longer helping the venous blood drain out of your head. Venous return slows down, which naturally increases the volume of blood in the skull slightly.
Oh, I see.
Yeah, for you or me, our brain complies, no problem. But for a patient whose suitcase is already full, that slight volume increase from laying flat pushes them over the edge into pain.
That makes total sense. Okay, let's move to the late dangerous signs, the ones that mean we are actively losing the battle and herniation is imminent.
The most terrifying late sign is Cushing's triad. It is an absolute medical emergency signaling that the brainstem is actively being compressed.
Let's unpack the triad. What are the 3 pieces? And more importantly, why are they happening? Let's connect the patho to the symptoms.
First, you will see systolic hypertension with a widening pulse pressure, meaning the top number, the systolic, shoots way up, say to 190 or 200, while the bottom number, the diastolic, stays the same or even drops.
Why does the systolic shoot up?
Because the brain is hypoxic, it sends a panic signal to the sympathetic nervous system to clamp down on peripheral blood vessels. It's trying to create a massive systemic blood pressure to physically force arterial blood up into the highly pressurized skull.
It's trying to overcome the resistance.
Exactly.
Okay, so the body is jacking up the blood pressure to save the brain. What's the second part of the triad?
Bradycardia, a slow, full, bounding heart rate.
Wait, if the sympathetic nervous system is firing to raise blood pressure, shouldn't the heart rate be fast? Tachycardia?
You would think so. But the massive systemic blood pressure triggers the baroreceptors in the aortic arch. They sense this dangerously high pressure and send a signal via the vagus nerve to the heart to slow down, trying to protect the heart from blowing out.
So you get this paradox, sky-high blood pressure with a heart rate dropping into the 40s?
It is chilling to see on a monitor.
Wow. Okay. High systolic with wide pulse pressure, bradycardia, and the third piece.
Irregular respirations. Often Cheyne-Stokes respirations, where they breathe fast and deep, then shallow, then stop breathing for a period of apnea. This happens because the physical pressure is finally crushing the respiratory control center in the medulla.
So Cushing's triad, widening pulse pressure, bradycardia, irregular breathing, and other late signs would be pupil changes, right? Like a unilateral fixed and dilated pupil.
Yes, a blown pupil on one side. That happens when the temporal lobe starts to shift and physically pinches cranial nerve the third, the oculomotor nerve. If you see that, the brain is actively herniating. You also see posturing. Decorticate, which is abnormal flexion, pulling the arms tight into the core like they are protecting their chest.
Right, drawing into the core.
And then decerebrate, which is abnormal extension arms, stiffly extended outward and rotated.
Which one is worse?
Decerebrate is generally worse. It indicates damage much deeper in the midbrain or brainstem.
All right, let's talk about how we actually monitor this pressure before we see Cushing's triad. We have CT and MRI for imaging, of course, but for moment-to-moment ICU monitoring, the ventriculostomy is the gold standard. And there's also the LICOX catheter. I want to know what these numbers and waveforms actually mean.
Let's start with the LICOX. It's a catheter inserted into the white matter of the brain. It measures brain tissue oxygenation, known as PbTO2, and brain temperature. Normal PbTO2 is 20 to 40 millimeters of mercury.
So it's not like an SpO2 finger probe measuring oxygen saturation in the blood. It's measuring the actual oxygen tension in the tissue itself.
Exactly. If you see a PbTO2 less than 20, that means regional ischemia. The oxygen is not extracting into the tissue, the cells are starving, and that lethal vasodilation cycle is about to start.
And the ventriculostomy. This is the catheter that goes directly into the lateral ventricle of the brain, right? It measures the ICP, but it also allows us to drain fluid.
Yes. It gives you a continuous ICP number, but more importantly, it gives you a waveform. If you look at the monitor, a normal ICP wave has 3 distinct bumps per heartbeat, looking almost like a staircase going down. P1, P2, and P3.
Okay, break those down for me.
P1 is the percussion wave. It represents the arterial pulse of blood shooting into the brain. It should be the highest peak. P2 is the tidal wave. It represents brain compliance, how much stretch or give the brain tissue has. P3 is the dicrotic wave, representing the closure of the aortic valve.
So it should look like stairs going down. P1 is the highest, then P2 is lower, P3 is the lowest.
Exactly. But if the brain is swelling and losing compliance, meaning the suitcase is completely full, that P2 wave will start to rise. When you look at the monitor and see P2 riding higher than P1, it means ventricular compliance is poor.
The brain has lost its ability to accommodate even a tiny drop more volume. That is such a crucial visual cue for a nurse. If P2 is higher than P1, you are on the edge of the cliff. So let's transition into nursing actions. You're the nurse. You notice that subtle LOC change. The attention span is dropping. What is your immediate ADPIE thought process?
My diagnosis is inadequate tissue perfusion and decreased intracranial adaptive capacity. My plan, my measurable goal, is to maintain the ICP less than 20 and maintain the cerebral perfusion pressure, the CPP, greater than 60.
Let's pause right there. CPP, cerebral perfusion pressure. Break down the math for me because this trips up a lot of people.
Sure. CPP is the net pressure required to physically push arterial blood into the brain against the resistance of the ICP. The formula is MAP minus ICP. mean arterial pressure minus intracranial pressure.
MAP minus ICP equals CPP.
Yes. A normal CPP is 60 to 100 millimeters of mercury. If your CPP falls below 50, your brain is ischemic. Less than 30 is incompatible with life. The brain tissue is dead.
Let's do a scenario. Let's say my patient's MAP is 90. Their ICP is 15. 90 minus 15 is 75. So my CPP is 75. We're in the safe zone of 60 to 100.
Exactly.
But let's say the patient gets a little agitated. They cough. Their ICP spikes to 25. And at the same time, the propofol drip they're on drops their systemic blood pressure, so their MAP falls to 70. Now, I have a MAP of 70 minus an ICP of 25. That equals 45.
And at a CPP of 45, the brain is actively dying. This is why we have to maintain a relatively strong systemic blood pressure in these patients. But there's a catch here, a concept called autoregulation.
Which is the brain's ability to adjust its own vessel diameter to keep blood flow constant.
Yes. But autoregulation totally fails if the systemic MAP drops below 70 or goes above 150. If the MAP is 60, the brain can't dilate vessels enough to save itself. If the MAP is 160, the high pressure just blasts into the damaged brain, worsening edema. So you have a tightrope to walk with your vasopressors and fluids.
Okay, let's talk about priority nursing actions. If my patient's ICP is spiking, or I'm trying to prevent it from spiking, rank my actions. What is my first, next T, and then?
First, always maintain a patent airway. If their Glasgow Coma Scale drops below 8, you intubate. Period. Less than 8, intubate. If you walk in and hear snoring sounds in an altered patient, that is an airway obstruction from the tongue dropping back.
It is not just deep sleep.
Right. Fix the airway immediately because hypoxia, as we discussed, causes vasodilation and rapidly worsens ICP.
Airway is secured. What is next T?
Next T, optimize their physical position. Head of the bed elevated to 30 degrees, not flat and not 90 degrees. 30 is the sweet spot.
Yeah.
And you must keep the neck midline and neutral.
Why is the neck position so critical?
Because the venous blood drains out of the skull via the jugular veins in the neck. If the patient's head is twisted to the side or flexed down onto their chest, you are physically kinking the jugular veins. You are trapping all that venous blood inside the skull. Keep the head straight.
Wow, that's such a simple mechanical fix that could save a life. Keep the drain pipes open. Okay, what is then?
Then you limit interventions that spike pressure. Suctioning the endotracheal tube is necessary, but it massively spikes ICP because it induces a cough reflex. So you must limit suctioning to less than 10 seconds per pass, maximum of 2 passes, and you always pre-oxygenate with 100% O2 beforehand to prevent that hypoxic vasodilation.
And what about the environment?
Total control. Dim lights. Limit visitors. Cluster your care, but if clustering causes their ICP to stay elevated, space the care out. Prevent shivering at all costs because shivering massively increases the brain's metabolic demand for oxygen.
Let's move to medications. This is where we break out the heavy hitters. We've got mannitol and we've got hypertonic saline. Both are osmotic therapies used to literally pull water out of the brain. But how do we choose between them?
Let's start with mannitol. It is an osmotic diuretic given IV. It works in 2 phases. Instantly, it expands the blood plasma, which reduces blood viscosity in a hematocrit. This makes the blood thinner so it flows better, which tells the brain it can constrict its vessels a bit. Then the osmotic phase kicks in.
This is the sponge effect.
Right. Mannitol creates a high osmotic gradient in the blood. It acts like a chemical sponge, drawing free water directly out of the swollen brain tissue, across the blood-brain barrier, and into the vascular space where the kidneys then pee it out.
So what's the catch? Why not use it for everyone?
Because it's a diuretic. It pulls fluid out of the whole body. You must check serum osmolality before giving it. If their blood is already too concentrated osmolality over 320, you hold it. You also hold it in severe renal disease because the kidneys can't clear it.
So what if we can't use mannitol or we need something else?
We use hypertonic saline, usually 3% saline, sometimes higher. It works via the same osmotic principle. It severely concentrates the sodium in the bloodstream, creating a massive osmotic pull of water out of the edematous brain cells.
But unlike mannitol, it doesn't make you pee it out, right? It just keeps the fluid in the vascular space.
Exactly, which means the blood volume expands drastically. You have to monitor their blood pressure and listen to their lungs obsessively because pulling all that fluid into the vascular space can easily cause severe fluid overload and pulmonary edema. You also must check serum sodium constantly. We usually target a slightly high sodium level, around 145 to 155, but you don't want to go into dangerously high levels.
What about sedation? Keeping the patient calm is critical to keeping the metabolic demand low.
We prefer propofol or dexmedetomidine, which is Precedex.
Why those specifically over, say, a continuous drip of a benzo like lorazepam?
Because of the half-life. Propofol and Precedex have very short half-lives. If I have a neuro patient, I need to know what their actual brain is doing. I can turn off the propofol drip, and within 5 to 10 minutes, the drug clears enough for the patient to wake up. I can perform a totally accurate neuro check, see if they squeeze my fingers, check their pupils, and then turn the sedation right back on. You cannot do that with long-acting benzodiazepines. They just stay snowed for hours.
And if the ICP is totally refractory to sedation, to mannitol, to everything, what is the final medical step?
High-dose barbiturates, like pentobarbital. We use this to induce a barbiturate coma. It drastically cuts the brain's metabolic demand. We titrate the drip until the continuous EEG shows burst suppression, meaning the brain waves are almost completely flat, just tiny bursts of activity. We are putting the brain to sleep to save it from itself.
That is intense. Let's touch on the ventriculostomy procedure itself. As the bedside nurse, what is my biggest trap here? What is the thing I cannot mess up?
Leveling the transducer. The ventriculostomy drain relies on gravity. The transducer must be leveled precisely to the tragus of the patient's ear.
The tragus, that little cartilage flap at the front of the ear canal, why there?
Because anatomically, the tragus aligns perfectly with the foramen Monro inside the brain, which is the exact point of the ventricles. You have to re-level this transducer with a laser level every single time the patient is repositioned, even an inch.
What happens if I forget? Say the patient slides down in bed, so now their head is lower than the transducer.
If the transducer is too high relative to their head, the monitor will falsely read a low ICP. You will look at the monitor, think they are fine, and completely miss a life-threatening pressure spike.
Oh, wow. And what if I lower the bed and the transducer is now too low, below their ear?
If the transducer is too low, the monitor will read a falsely high ICP, and the system might overdrain cerebrospinal fluid out of the skull. If you drain CSF too fast, the ventricles can literally collapse on themselves, or you can cause a subdural hematoma as the brain shrinks away from the skull.
So exact leveling to the tragus every single time. And obviously strict aseptic technique, because a straight line into the brain is a highway for infection.
Non-negotiable sterility, absolutely.
Okay, let's talk fluids and electrolytes broadly. We have to keep these patients euvolemic. We don't want them dry. We don't want them overloaded. We are monitoring closely for 2 classic pituitary complications, diabetes insipidus, or DI, and syndrome of inappropriate antidiuretic hormone, or SIADH.
Yes. The pituitary gland is sitting right at the base of the brain, easily compressed by swelling. If it stops secreting ADH, you get diabetes insipidus. The patient will suddenly dump massive amounts of dilute urine liters an hour. Their serum sodium will skyrocket because they're losing all their free water.
And SIADH is the exact opposite.
Right. The damaged pituitary dumps too much ADH. The patient stops peeing entirely. They retain all their free water, which dilutes their blood, causing a dilutional hyponatremia. Low sodium in a neuropatient is incredibly dangerous because it pulls water into the cells, worsening brain edema.
Speaking of fluids pulling water into cells, what IV fluids are we hanging for our routine piggybacks or maintenance?
Use 0.9% normal saline for everything. Never, under any circumstances, hang D5W or 0.45% normal saline for a neuropatient.
Because they are hypotonic.
Yes. D5W is isotonic in the bag, but the moment it enters the bloodstream, the body metabolizes the dextrose, leaving behind only free water. Free water is incredibly hypotonic. It lowers the serum osmolality of the blood. Because of osmosis, that water will flee the vascular space and drive directly into the cells. In a brain that is already swelling, hanging D5W will cause a massive spike in cerebral edema. It is a fatal error.
Good to know. Normal saline only. Let's summarize deterioration. We've talked about the mechanisms, but if I'm looking at my patient, how do I know they are getting worse before herniation actually happens?
The patient is getting worse if you look at their ventriculostomy monitor and that P2 wave starts riding higher than P1. That means they have lost compliance. They're getting worse if you're checking vitals and you see their systolic blood pressure slowly trending up over an hour while their heart rate is slowly trending down. That is Cushing's triad knocking at the door. And they're getting worse if you do a pain stimulus check and their previous decorticate flexion turns into decerebrate extension. The damage is moving deeper into the brainstem.
What's the escalation protocol here? What's a notify the doctor versus a call a code?
If you see a gradual ICP drift upward, say it goes from 14 to 18 over an hour, you notify the provider. But first, assess your own interventions. Are they in pain? Do they have full bladder? Are their endotracheal ties too tight around their neck, blocking venous return? Fix the nursing issues first, then call.
And the immediate emergency.
If you shine a light in their eyes and you see a sudden Unilateral fixed and dilated pupil. That is not a call and wait for a callback. That is a code or immediate intervention. That is uncle herniation happening right in front of you. You immediately notify the provider and the neurosurgeon, ensure the airway is clear, hyperventilate the patient briefly to drop CO2 and constrict vessels, and prepare for emergency surgical decompression.
Let's hit a quick ICU pearl or an exam trap. I see this all the time with novice nurses. You walk in, the patient is unconscious, but they squeeze your hand when you put yours in their palm.
Do not be fooled by the hand squeeze. In an unconscious patient, hand squeezing is very often a primitive palmar grasp reflex. It means nothing about their actual cortical function. Novice nurses will chart follows commands, purposeful movement, because the patient squeezed their hand.
So how do we actually test purposeful motor response?
You apply a noxious stimulus, a trapezius pinch or supraorbital pressure. You watch what they do. If they reach up, cross the midline, and try to bat your hand away, they are localizing pain. That is purposeful. If they just rigidly flex their arms inward, that is abnormal decorticate posturing. Big difference.
Another traphengy tubes.
Yes. If a patient has severe facial trauma or a suspected basilar skull fracture, you never insert a nasogastric tube. The cribriform plate, the bone separating the nasal cavity from the brain, could be shattered. If you push an NG tube up the nose, you can go straight through the fracture and coil up inside the frontal lobe of the brain. You must use an oral gastric tube instead.
That is literal nightmare fuel. Okay, let's tie this whole first section together with some intensivist thinking. This is how we want our listeners to process information. Okay, problem. Your neuropatient develops a fever of 101.5, failing physiology. The increased temperature spikes the metabolic demand of the brain tissue.
Exactly.
Immediate threat. Because the brain is hotter, it demands more oxygen. To get that oxygen, it triggers cerebral vasodilation. Those dilated vessels steal space in the skull, leading to an imminent ICP spike. Intervention. Aggressive cooling measures. Ice packs, cooling blankets, and antipyretics like acetaminophen. But crucially, you must monitor them to ensure they do not start shivering.
Spot on.
And reassessment. Recheck the core temp and watch the ICP waveform return to normal compliance.
That is beautiful. That is exactly how an elite ICU nurse thinks. You don't just treat the fever to make the number go down. You treat the fever because you know the heat is physically dilating blood vessels inside a closed box.
So if we had to distill this entire foundation into our Pareto 80-20, if you remember only 5 things from intracranial regulation. Number 1, core patho. Hypoxia and hypercapnia cause cerebral vasodilation, which steals limited skull space and specs pressure.
Number 2, key assessment. A subtle change in level of consciousness is the earliest sign. Cushing's triad high systolic, low heart rate, irregular breathing is a late fatal sign.
Number 3, most dangerous complication. Brainstem herniation.
Number 4, priority nursing action. Maintain the airway and elevate the head of the bed to 30 degrees with the neck perfectly neutral.
Number 5, most important treatment. Osmotic therapy like mannitol or hypertonic saline combined with CSF drainage.
And your one-sentence clinical picture for this section. An unconscious patient with a ventriculostomy whose rising blood pressure and dropping heart rate signal impending brainstem compression.
The action trigger. If you see a sudden unilateral fixed and dilated pupil, think uncle herniation and do immediately notify the neurosurgeon while preparing for emergency decompression. Okay, so now that we deeply understand the mechanics of normal pressure and swelling, what happens when an external force suddenly shatters that equilibrium? Let's talk trauma. This is section 2, traumatic brain injury and hematomas.
TBI is essentially physical damage to the scalp, skull, or brain. It can be diffuse, meaning spread out across the entire brain like a severe concussion, or it can be focal, localized to one specific spot, like a contusion or a bleed.
Why does the ICU nurse's role matter so much here? I mean, if the trauma already happened, what are we actually doing?
Because of the timeline of death. Most TBI deaths occur immediately at the scene from the primary impact. We can't do anything about that. But the second wave of death happens hours or days later. The ICU nurse is the one who prevents those delayed deaths. The deaths from the secondary injury, the expanding bleeds, the ischemia, the edema.
Who is getting these TBIs? We usually think of young guys on motorcycles.
Yes, falls and motor vehicle accidents are the top causes. Men are twice as likely as women to suffer TBI. But there's a massive, incredibly vulnerable risk group that we see constantly. Older adults on anticoagulant medications.
Like Eliquis or warfarin.
Right. For an 80-year-old on a blood thinner, a minor fall from a standing height that just causes a little bump on the head can turn into a lethal, slow-pooling bleed. We have to be hyper-vigilant with that demographic.
Let's dig into the pathophysiology of specific injuries. Let's start with diffuse axonal injury, or DAI. When I first learned about this, I pictured the brain violently shaking and the axons, the long cables connecting the neurons, just physically snapping in half on impact.
That's what we used to think.
Yeah.
But research shows it's actually much more insidious. The initial trauma, the rapid acceleration and deceleration of the brain, doesn't usually tear the axons right away. Instead, the shearing forces stretch the axons and change their cellular function. They damage the cytoskeleton.
So what happens next?
Over the next 12 to 24 hours, the damaged axons lose their ability to transport proteins. They start to swell. They balloon up until they finally disconnect and undergo Wallerian degeneration. It's an evolving injury. This is why a patient might look okay on a CT scan at hour 1, but by hour 24, they're in a deep coma. The axons literally swelled themselves to death.
And what about coup contra coup injuries? This is a classic term.
This happens in high-velocity impacts. Say you're in a car and you hit a brick wall. Your skull stops instantly, but your brain, which is floating in fluid, keeps moving forward. The brain strikes the front of the inside of the skull. That's the coup injury, the primary impact.
Usually the frontal lobe getting bruised.
Right. But then the brain rebounds. It bounces backward off the front of the skull and slams into the back of the skull. That's the contra coup injury. So you end up with massive contusions on opposite sides of the brain. And fascinatingly, because of the physics of the fluid dynamics, the secondary impact, the contra coup of the back of the head, is often actually worse than the initial front impact.
Wow, okay. Let's move to the assessment of trauma. Let's talk about skull fractures, specifically the basilar skull fracture. This is a break in the bones at the base of the skull. What are the classic signs we are hunting for?
You are looking for cerebrospinal fluid leaking out of the body, rhinorrhea, which is CSF leaking from the nose, and otorrhea, which is leaking from the ears. The dura has been porn, so the fluid just drips out.
But how do I know if it's CSF and not just a runny nose from crying or trauma?
You use the halo sign. If clear or slightly bloody fluid is leaking from the ear or nose, you let it drip onto a clean white gauze pad. You wait a few minutes. If it's CSF mixed with blood, the heavier red blood cells will coalesce in the center of the drop. The lighter CSF will fan out around it, creating a distinct yellowish ring, a halo encircling the blood.
That is such a cool, practical bedside test.
It is. You also look for battle sign, which is postauricular ecchymosis, severe bruising right behind the ears over the mastoid bone, and raccoon eyes, which is bilateral periorbital bruising. Both indicate blood pooling at the base of the skull from a fracture.
Now let's talk about the big scary ones, the hematomas. Epidural versus subdural. I want to spend some time here because the difference in how these act is wild. What is an epidural hematoma?
An epidural hematoma is bleeding into the space between the tough outer layer of the brain, the dura mater, and the inner surface of the skull. It is almost always an arterial bleed, typically a tear in the middle meningeal artery, often caused by a linear fracture of the temporal bone.
And because it's arterial, it's under high pressure.
Yeah.
Imagine a high-pressure water main bursting inside a wall versus a slow leak from a garden hose. The epidural is the bursting water main.
Exactly. It fills the epidural space incredibly fast. This creates a highly specific, classic clinical presentation that you must recognize. The patient suffers the trauma and is knocked unconscious at the scene.
That's the initial impact.
Right. Then they wake up. This is the lucid interval. They might be totally awake, talking to you, asking what happened to their car. But while they are talking to you, that torn meningeal artery is pumping high-pressure blood into the skull, stripping the dura away from the bone and creating a massive pool of blood.
The suitcase is filling up.
Rapidly. Once the compliance is maxed out, the patient experiences a catastrophic rapid decrease in LOC. They go from talking to you, to confused, to slurring their words, to comatose, to blown pupil, to posturing within minutes as the arterial blood crushes the brain inward. It's an absolute drop-everything neurologic emergency. They need a burr hole or craniotomy immediately to evacuate the blood.
Okay, that's the epidural. What about the subdural hematoma, the slow garden hose?
A subdural hematoma is bleeding between the dura mater and the arachnoid layer underneath it. This bleed is usually venous. It comes from the tearing of the small bridging veins that drain the surface of the brain into the sagittal sinus.
And because veins are low-pressure systems, it develops much more slowly.
Right. An acute subdural presents within 24 to 48 hours of the injury. A subacute might take 2 to 14 days to show signs, and a chronic subdural hematoma can take weeks or even months to present.
This is where that differential pattern recognition is so fascinating. Let's talk about the elderly and the chronic subdural. Imagine you have an 80-year-old patient presenting to the ER with new onset confusion, memory loss, and lethargy. The family says they are acting bizarrely.
The immediate instinct is to think stroke, or the rapid onset of dementia, or a UTI. But you must ask the family, did they fall in the last month?
Why does it take a whole month?
2 reasons. First, the venous bleed is very slow. Second, older adults naturally have some brain atrophy. Their brain actually shrinks as they age, which means there is more empty space inside the skull. When the bridging vein tears from a minor bump on the head, the blood just slowly pools into that extra space. It can pool for weeks without causing any pressure symptoms. But eventually, the pool gets big enough that it finally presses on the brain tissue.
It's honestly terrifying to think that a slow venous bleed can totally mimic Alzheimer's disease. You could have a patient placed in memory care when in reality they just need a burr hole to drain the old, dark blood off their brain.
It happens, which is why any elderly patient with new onset confusion gets a CT scan, especially if they are on Eliquis or warfarin.
Diagnostics for TBI. The non-contrast CT scan is the absolute gold standard for rapid trauma diagnosis. It shows fresh blood instantly as bright white.
And we must always assume a cervical spine injury with head trauma. The forces required to damage the brain almost always put the neck at risk. C-spine CTs or X-rays are mandatory, and the patient stays in a rigid cervical collar until cleared by a doctor.
From an ADPIE perspective, your assessment priority is hunting for those subtle fluid leaks, checking the pillowcase for a halo sign. Your nursing diagnosis is risk for ineffective cerebral tissue perfusion.
Your planning is entirely focused on preventing secondary ischemia. Keep the oxygen up, keep the blood pressure stable.
For implementation, you mentioned earlier that we can test nasal drainage for glucose to see if it's CSF.
Yes, using a dextrosticks. Normal mucus does not have glucose. Cerebrospinal fluid does. If it tests positive for glucose, it's CSF.
But there's a huge exam trap here, right?
Yes. If there is blood mixed in the fluid, the glucose test is completely invalid. Blood contains its own glucose. If you test a bloody nose, it will test positive for glucose, and you might falsely assume they have a skull fracture. If blood is present, throw the dextrosticks away and rely entirely on the halo sign on the gauze pad.
So good. What are my priority nursing actions in the trauma bay or the ICU when a severe TBI rolls in?
First, stabilize the cervical spine while simultaneously managing the airway using the jaw thrust maneuver, not the head tilt chin lift, to protect the neck. Next T, apply high-flow oxygen via a non-rebreather mask and establish 2 large-bore IVs for fluid resuscitation. Then, control any massive external bleeding with sterile pressure dressings.
For medications, we talked about sedation earlier. In trauma, do we want them sedated?
It's a delicate balance. If their ICP is fine, we actually want to avoid heavy sedatives initially if possible, because they mask our serial neuro assessments. We need to know if they're waking up or deteriorating. But we do routinely use prophylactic anti-seizure medications, like levetiracetam or phenytoin, for the first 7 to 10 days after a severe TBI.
Because a seizure would skyrocket their metabolic demand and their ICP.
Exactly. Post-traumatic seizures are common and devastating.
Procedures. We've mentioned burr holes for rapid decompression of an epidural bleed. What is the difference between a craniotomy and a craniectomy?
In a craniotomy, the neurosurgeon cuts a flap of bone out of the skull, goes in, stops the bleeding, evacuates the hematoma, and then puts the bone flap back in place, securing it with plates. The skull is closed. In a craniectomy, they remove the bone flap and they leave it off.
Wait, they just leave a hole in the skull?
Yes. They usually tuck the bone flap into the patient's abdomen, just under the fat layer, to keep the bone tissue alive and sterile. They leave the skull open because they know the brain is going to swell massively over the next few days. By removing the bone, they give the swollen brain room to expand outward instead of herniating downward into the brainstem. Months later, when the swelling is gone, they do a cranioplasty to put the bone back.
Hemodynamics and fluids for trauma. We mentioned maintaining normothermia. Fever is bad.
Very bad. Shivering is worse. And we give fluids very cautiously. We need a strong blood pressure to maintain CPP. But overzealous fluid resuscitation can exacerbate cerebral edema. You might need vasopressors instead of just dumping liters of saline into them.
Let's do some intensivist thinking for trauma. Problem. The patient has a confirmed basilar skull fracture. Failing physiology and threat. The duramater is torn at the base of the skull. This opens a direct, unsealed pathway for bacteria from the sinuses, the nose, or the ears directly into the sterile brain cavity. The immediate threat is fulminant meningitis. Action. Advocate for prophylactic antibiotics. And crucially, as the nurse, you strictly avoid any nasal insertions. No nasal intubation, no nasogastric tubes, and no nasal suctioning.
Perfect. You are recognizing that the structural damage creates an infection highway, and you are altering your nursing care to prevent driving a tube up that highway.
And what about packing a leaking nose or ear?
Never pack it. If CSF is leaking out, let it leak. Place a loose, sterile pad under the nose or ear to catch the fluid and change it when soiled. If you plug the leak with packing, you increase the intracranial pressure, and worse, you force the dirty infected fluid to backwash into the brain.
Let's summarize TBI with our 5 things to remember. Number 1, core patho. Arterial bleeds like epidural hematomas kill fast due to high pressure. Venous bleeds like subdural hematomas kill slowly.
Number 2, key assessment. The halo sign confirms CSF leakage from a skull fracture. Do not use the glucose test if blood is present.
Number 3, most dangerous complication. An unrecognized epidural hematoma entering the rapid deterioration phase.
Number 4, priority nursing action. Assume a neck injury and stabilize the C-spine simultaneously with securing the airway.
Number 5, most important treatment. Immediate surgical evacuation for large symptomatic hematomas.
And your one-sentence clinical picture for TBI. A trauma patient who briefly woke up but is now rapidly losing consciousness as a torn meningeal artery fills their skull with blood.
Action trigger. If you see clear fluid dripping from the nose after head trauma, think basilar skull fracture and do tests for glucose, while strictly avoiding any nasal tubes.
Which brings us perfectly into Section 3, brain tumors and cranial surgery. We just talked about trauma, which is the sudden occupation of space. The suitcase is filled in seconds. But tumors are completely different. The space occupation is incredibly gradual.
This is all about the compliance curve of the brain, right? The curve is relatively flat for a long time.
Saying the brain adapts.
Right.
As the tumor slowly grows over months, the brain gradually pushes out more and more CSF and venous blood to make room. The patient might be totally asymptomatic.
Right.
But eventually, you reach the end of the flat part of the curve and hit the steep vertical wall. The compensation is maxed out. At that point, even a tiny millimeter of tumor growth causes a massive exponential spike in ICP.
So the 80-20 overview here. We are dealing with primary or metastatic cell growth in the brain. It matters because, unlike tumors in the rest of the body, even histologically benign tumors are deadly if they grow in an inaccessible area and raise ICP.
Exactly. A benign meningioma that can't be removed will kill you just as surely as a malignant glioblastoma simply by crushing the brainstem. The must-know facts. Metastatic tumors are the most common brain tumors overall, usually spreading from the lung or the breast. If we were talking about primary tumors that start in the brain, meningiomas are the most common.
Let's look at the pathophysiology of how these tumors actually cause damage, aside from just taking up physical space.
The real enemy here is vasogenic edema. As the tumor grows, it infiltrates local tissue and demands its own blood supply. But the blood vessels that the tumor builds are poorly constructed. They lack the tight junctions of a normal blood-brain barrier.
The blood-brain barrier is usually highly selective, right? It keeps the large stuff out of the brain tissue.
Yes, but the tumor's vessels are leaky. This disruption allows large molecules, like proteins, to leak directly from the blood into the interstitial brain tissue. And basic osmosis dictates that water follows protein,
So the leaky proteins pull free water out of the blood and into the brain.
causing massive localized swelling in the extracellular space surrounding the tumor. If the tumor is located near the ventricles, its physical mass can also clamp down and obstruct the normal flow of CSF, causing hydrocephalus, which just adds more pressure to the system.
Assessment. We mentioned this earlier, but the classic sign of a brain tumor is a dull, constant headache that is worse at night, or that awakens the patient from a dead sleep. And again, that's because laying flat removes the gravity assist for venous drainage, spiking the ICP just enough to cause pain.
You also need to look for new onset seizures in an adult. If a 45-year-old with no history of epilepsy suddenly has a grand mal seizure, a brain tumor is at the absolute top of the differential list. The tumor acts as an irritant to the electrical pathways.
And what if the tumor is in the frontal lobe?
The frontal lobe controls executive function, personality, and emotional regulation. A patient with a frontal lobe tumor might present with bizarre personality changes.
This is a great differential pattern recognition moment. Imagine you have a previously stable professional adult. Suddenly, they start losing emotional control, they become highly impulsive, making wildly inappropriate comments, or having sudden outbursts of rage.
Right, the family thinks they're having a midlife crisis or a psychiatric breakdown or just acting out of bad behavior. But if you see that sudden loss of inhibition, you have to think frontal lobe lesion. The physical hardware running their personality is being crushed. It is vital to support the family through that because watching a loved one's personality disintegrate is devastating, and they need to understand it is a physical disease, not a choice the patient is making.
Diagnostics for tumors rely heavily on the MRI. It is highly sensitive for small lesions, much better than a CT scan for tissue detail. And then a tissue biopsy, often using stereotactic guidance, determines the exact histology, whether it's an astrocytoma, a glioblastoma, etc.
For your ADPIE, your assessment before surgery must establish a rock-solid baseline. You need to know exactly what their LOC is, their motor strength out of 5, their sensory function. You need to know that before they go to the OR, so when they come back to the ICU, you know if a deficit is new from the surgery or if they already had it.
The nursing diagnosis is risk for injury related to seizures or altered behavior. Planning is to maximize neurologic functioning and control pain. Implantation means protecting them from self-harm padded side rails if they are seizing, close supervision if their judgment is impaired.
And let's talk about priority nursing actions after they come back from cranial surgery.
What is my first, next T, and then?
First, prevent increased ICP. And the most immediate way you do that post-op is with precise head-of-bed positioning. But it depends on the surgery. If they had a supratentorial surgery, meaning above the tentorium in the cerebral hemispheres, you elevate the head of the bed 30 to 45 degrees to promote venous drainage.
And if they had an infratentorial surgery, down in the cerebellum or brainstem?
You keep them flat or slightly elevated at 10 to 15 degrees, and you do not flex their neck.
Okay, what is next T?
Next T, monitor that surgical dressing obsessively. You're looking for excess bleeding, obviously, but you are specifically hunting for clear drainage. If you see excessive clear fluid soaking the dressing, that is a CSF leak,
And then
administer antiemetics at the first sign of nausea. The physical act of retching and vomiting causes massive spikes in intrathoracic pressure, which translates directly to massive spikes in intracranial pressure. You must prevent them from throwing up.
But there is a caveat with the antiemetics, right?
Yes. Avoid promethazine or Phenergan, if possible. It causes severe somnolence and sedation. If you knock the patient out with Phenergan, you ruin your ability to do an accurate hourly neuroassessment. Use ondansetron, Zofran, instead.
Medications for tumors. We use a corticosteroid here, dexamethasone.
Yes, dexamethasone is crucial. It directly treats that vasogenic edema we talked about earlier. It stabilizes the cell membranes and tightens up the leaky blood-brain barrier around the tumor, drastically reducing the swelling.
But wait, earlier in the TBI section, you explicitly said we do not use steroids for head trauma.
Correct. That is a massive NCLEX and critical care exam trap. Steroids are not recommended for traumatic brain injury. They have been shown to increase mortality and trauma. But for tumors and infections, dexamethasone is a primary treatment.
What about chemotherapy?
The most common is temozolomide or Temodar. It's an oral chemo drug. The brilliant thing about it is that it spontaneously converts in the body into a form that can cross the blood-brain barrier, which most chemo drugs cannot do.
But the nursing monitoring for it.
It causes severe myelosuppression. You have to monitor their absolute neutrophil count and their platelets closely because they are at high risk for infection and bleeding.
Let's talk post-op complications, specifically ventricular shunts. If a tumor causes hydrocephalus, the surgeon might place a shunt to route the excess CSF from the ventricles down into the peritoneal cavity in the abdomen, where the body reabsorbs it.
The most dangerous complication here is a shunt malfunction. The tubing gets blocked by protein or blood.
So the patient is getting worse if they have a ventricular shunt and they suddenly develop a decreasing LOC, restlessness, and start vomiting.
That is classic shunt failure. The fluid is backing up into the brain, causing acute hydrocephalus. It requires immediate surgical revision.
And for escalation, what if they have those symptoms, but they also have a fever and a stiff neck?
You notify the provider immediately because that is a shunt infection. The hardware is infected, tracking bacteria directly into the ventricles.
Here's a huge ICU pearl for positioning. We talked about craniectomies earlier, where the bone flap is removed and left off.
Yes. If the patient has had a craniectomy, you never, under any circumstances, position the patient on the operative side.
Because there is no bone protecting the brain.
Right. If you lay them on that side, the physical weight of their head is resting entirely on unprotected, swollen brain tissue. You will cause immense ischemia and damage. Always place a sign at the head of the bed, alerting the entire care team to the craniectomy site.
Intensivist thinking for tumors. Problem. Post-op cerebral edema around the resection site. Threat. Increased ICP and herniation. Intervention. Administer ordered corticosteroids like dexamethasone, maintain precise head positioning based on the surgical site, and prevent vomiting. Reassessment. monitor the LOC hourly, and check the dressing for clear CSF leaks.
Beautifully summarized. If you remember only 5 things for brain tumors. Number 1, core patho. Tumors cause vasogenic edema by building leaky blood vessels that disrupt the blood-brain barrier.
Number 2, key assessment. Headaches that are worse at night or wake the patient up from sleep.
Number 3, most dangerous complication. Post-op cerebral edema or an acute hemorrhage into the tumor bed.
Number 4, priority nursing action. Precise head positioning post-op and absolutely never on the craniectomy side.
Number 5, most important treatment. Surgical resection combined with targeted radiation or chemotherapy.
And the one-sentence clinical picture. An adult with new onset seizures and personality changes who requires meticulous ICP management and steroid therapy following a craniotomy.
Action trigger. If you see excessive clear drainage on a post-craniotomy dressing, think CSF leak and do notify the surgeon immediately while keeping the patient perfectly still to prevent further tearing.
Excellent. Let's move to the final piece of the puzzle. We've covered bleeding filling the space, we've covered mass growths filling the space, but what happens when the fluid itself becomes the enemy? Section 4, inflammatory conditions, meningitis and encephalitis.
In these conditions, severe inflammation is the primary driver of the ICP spike. Meningitis is the inflammation of the meninges, the protective layers around the brain, and the CSF itself. Encephalitis is the inflammation of the actual brain parenchyma, the tissue itself.
This matters incredibly because untreated bacterial meningitis is nearly 100% fatal. And unlike a tumor or a car crash, it is a massive contagion risk for the nursing staff and the other patients on the unit.
The must-know facts. Streptococcus pneumonia and Neisseria meningitidis are the top bacterial culprits. Viral meningitis is more common, but usually less severe. Viral encephalitis is often caused by herpes simplex virus, HSV, or mosquito-borne viruses like West Nile.
Let's trace the pathophysiology of bacterial meningitis. How does a simple sinus infection turn into a lethal brain swelling?
The organism enters the central nervous system, usually crossing over from the respiratory tract or the bloodstream. Once inside the subarachnoid space, the bacteria multiply rapidly because CSF has no white blood cells to fight them off.
It's a perfect breeding ground.
Right. The immune system eventually realizes what's happening and triggers a massive systemic inflammatory response. Millions of neutrophils rush into the CSF. They fight the bacteria, and the resulting debris forms a thick, purulent exudate, pus.
The CSF, which is normally crystal clear, becomes this thick, cloudy, infected sludge.
Exactly. This thick exudate coats the surface of the brain. It wraps around and damages the cranial nerves. And critically, it physically clogs the arachnoid villi.
Remind me what the arachnoid villi do.
They are the structures that reabsorb the used CSF back into the venous bloodstream. They're the drains for the sink. If the thick pus clogs the drains, the brain is still producing 500 milliliters of CSF a day, but none of it can drain out.
So you get non-communicating hydrocephalus, the sink overflows.
The fluid builds up, the inflammatory mediators cause massive cerebral edema, and the ICP spikes drastically.
Let's talk assessment, the classic triad we all learn in nursing school.
Fever, severe headache, and neutral rigidity.
Neutral rigidity being a stiff neck. They physically cannot touch their chin to their chest because the meninges are so inflamed that stretching them causes excruciating pain.
Right. For bacterial meningitis specifically, you also look for severe photophobia, light hurts their eyes, and a highly specific sign, a petechial rash.
The tumbler test.
Yes. If the patient has a rash, press the base of a clear drinking glass, a tumbler, against the skin. If the rash is just normal inflammation, it will blanch, meaning it turns white under the pressure. But if it is a petechial rash from meningococcal meningitis, it will not blanch. You will still see the red or purple dots through the glass. This is because petechiae are actually tiny microhemorrhages under the skin, not just surface inflammation. It is a very bad sign.
And how does the assessment differ for encephalitis?
Because encephalitis is inflammation of the brain tissue itself, rather than just the fluid around it, you see much more pronounced mental status changes early on. Bizarre behavior, tremors, amnesia, chemioparesis. It looks a bit more like a stroke or a severe psychiatric event initially.
Okay, diagnostics. This is perhaps the most critical safety point in this entire deep dive. To diagnose meningitis, we need a sample of the CSF, which means a lumbar puncture, an LP. But there is a mandatory rule before you do an LP.
A CT scan of the head must be done before a lumbar puncture in any patient with suspected increased ICP.
I really want to understand the physics of why. What happens if a doctor just does an LP blindly on a patient with a swollen brain?
Think about the pressure gradient. Inside the skull, the pressure is massive. It's pushing downward, trying to find an exit. But the pressure in the spinal column below is also somewhat high, which holds the brain in place. If you insert a needle into the lower spine and open the system to the room air, you instantly drop the pressure in the spinal column to 0.
You create a vacuum effect.
Exactly. The massive high pressure in the skull instantly takes the path of least resistance. It forces the brain tissue violently downward through the foramen magnum. You will cause a catastrophic fatal brainstem herniation right there on the table. You always CT first to rule out a mass effect or severe obstruction.
Once the CT is clear and the LP is done, we analyze the fluid. What is the differential pattern between bacterial and viral CSF?
Bacterial CSF is turbid, cloudy, or even purulent. It has a massively high white blood cell count, predominantly neutrophils. The protein is high, over 500, because the bacteria and immune cells are made of protein. And critically, the glucose is LWR.
Because the bacteria are living organisms and they are literally eating the glucose in the fluid for energy.
Yes. Viral CSF, on the other hand, is usually clear or slightly cloudy. The white blood cells are elevated, but they are lymphocytes, not neutrophils. The protein is only slightly elevated, and the glucose is normal because viruses don't eat glucose.
From an ADPIE perspective assessment, you are doing the tumbler test on any rash and checking for neutral rigidity. Diagnosis: acute pain related to meningeal irritation and hyperthermia. Planning: resolve the infection and strictly control the fever.
For implementation, you keep the room dark because of the photophobia. You put a cool cloth over their eyes. You minimize all stimuli, no loud TVs, no constant alarms if possible, restrict visitors. The inflamed brain is hyperexcitable and excess stimulation can easily trigger a seizure.
Let's talk priority nursing actions because this is life or death for the patient and the staff. A patient rolls in with the triad: fever, headache, stiff neck. What is my first, next T, and then?
First, respiratory isolation. Immediately, droplet precautions.
Yeah.
Mask, gown, gloves for everyone entering the room. You keep them in isolation until the cultures come back negative or they've been on targeted antibiotics for 24 hours.
Protect the unit first. What is next T?
Next T, draw blood cultures and prep them for the CT and LP.
And
Then administer empiric 5E antibiotics immediately.
wait, immediately, before the LP results come back.
Yes, you draw the blood cultures first so the antibiotics don't ruin the blood sample. But you do not wait for the LP results to start the IV antibiotics. Bacterial meningitis duplicates incredibly fast. Every hour you delay antibiotics, the mortality rate jumps. Blast them with broad-spectrum antibiotics like ceftriaxone or ampicillin immediately.
Meds. We use a cyclover for HSV encephalitis.
Yes, and you must start it early before the patient falls into a coma for it to have maximum benefit. It limits viral replication.
For pain control in meningitis, the headaches are described as the worst of their life. Why do we often use codeine?
Codeine provides significant pain relief, but it does not alter the level of consciousness as profoundly as IV fentanyl or morphine. We need to be able to wake them up and track their neurostatus accurately.
Hemodynamics and fluids. We have to watch for septic shock dynamics, especially with meningococcal infections. But I want to talk about fluid replacement. These patients have fevers of 103, 104 degrees. They are sweating profusely. How do we calculate fluid replacement for hypermetabolism?
As a baseline rule of thumb, you calculate 800 milliliters per day for normal respiratory and insensible losses. Then you add 100 milliliters for every single degree of temperature over 38 degrees Celsius, or 100.4 Fahrenheit. They're losing massive amounts of free water through hypermetabolism and diaphoresis, and if you don't replace it, they will become severely hypovolemic, which drops their MAP, which drops their CPP, which kills the brain.
Let's talk about the most terrifying complication, Waterhouse-Friderichsen syndrome.
It is a devastating complication of meningococcal meningitis. The massive bacterial load in the blood causes disseminated intravascular coagulation, or DIC. They start clotting everywhere, consuming all their platelets, and then they start bleeding from everywhere.
Which is why we see the petechial rash.
Right. But worse, it causes bilateral adrenal hemorrhage. The adrenal glands bleed out and fail. Without cortisol, the patient loses all vascular tone and goes into profound, treatment-resistant circulatory collapse.
So the patient is getting worse if their petechial rash is rapidly spreading across their torso, or if they develop a cranial nerve palsy, like a drooping eyelid or a blown pupil, signaling brainstem compression.
And the escalation protocol is a code or immediate intervention if you see signs of DIC and shock. Dropping blood pressure, oozing from IV sites, spreading petechiae.
Here is a major ICU pearl regarding fever management. We said fever spikes the metabolic demand in the ICP, so I should just pack them in ice and put a cooling blanket on, maximum, right?
Absolutely not. You must treat the fever vigorously, but you must not reduce it too rapidly. If you use a cooling blanket, and you drop the skin temperature too fast, the hypothalamus panics and triggers violent shivering. Shivering generates heat, but it also massively increases the metabolic demand for oxygen, which will instantly spike the ICP.
So how do we prevent it?
You wrap their extremities, their hands and feet, in soft towels to keep the peripheral receptors warm and trick the brain, while you apply the cooling blanket to their core, and you give acetaminophen.
Intensivist thinking for infections. Problem. A college student presents with a stiff neck, photophobia, and a non-blanching rash. Threat. Highly contagious meningococcal infection leading to intravascular coagulation, adrenal failure, and lethal ICP spikes. Intervention. Immediate droplet isolation, aggressive fluid resuscitation, draw blood cultures, and administer empiric IV antibiotics without waiting for the LP reassessment. Monitor for spreading rash, worsening hemodynamics, and signs of herniation.
If you remember only 5 things for neuroinfections. Number 1, core patho. Purulent exudate blocks the arachnoid villi, preventing CSF drainage and causing massive ICP spikes.
Number 2, key assessment. Neutral rigidity, severe headache, photophobia, and a non-blanching petechial rash.
Number 3, most dangerous complication. Herniation from doing an LP without a CT scan, or Waterhouse-Fredrickson shock.
Number 4, priority nursing action. Initiate droplet isolation immediately and administer empiric antibiotics the second cultures are drawn.
Number 5, most important treatment. 4 antibiotics and dexamethasone to reduce the inflammation.
And your one-sentence clinical picture. A young adult presenting with a stiff neck, blinding headache, and a petechial rash who requires immediate isolation and aggressive antibiotic therapy.
Action trigger. If you see a patient with suspected meningitis, think highly contagious medical emergency, and do place them in isolation before doing anything else.
That really covers the landscape. We've gone from the elegant but unforgiving physics of the Monro-Kellie Doctrine and the packed suitcase. We've walked through the violent disruption of traumatic brain injury and the tragedy of the lucid interval. We've explored the insidious, slow expansion of tumors defeating the compliance curve, all the way to the toxic, purulent siege of bacterial infections.
It is a massive amount of information to process. But applying that 80-20 intensivist lens, always asking why the physiology is failing at a cellular level and what is going to kill the patient first, really cuts through the noise. You aren't just memorizing waveforms, you are understanding that a rising P2 waves means the brain has lost its stretch. You aren't just memorizing Cushing's triad. You are visualizing the crushed medulla desperately trying to pump blood into a pressurized vault.
Exactly. And I want to remind you, our listener, of your incredibly unique position in the healthcare team. In the ICU, the brain cannot advocate for itself. The monitors beep, the numbers flash, but they do not provide context. The context relies entirely on your vigilance. Your ability to translate a subtle 2-second delay in answering a question into life-saving osmotic therapy is what stands between the patient and secondary brain death. You are the ultimate translator of that black box.
So all said.
So what does this all mean? I want to leave you with a final thought to mull over as you head into your next shift. We spend our whole lives trying to expand our minds, right? Reading, learning, experiencing new things, growing. But in the neuro-ICU, a mind that expands is a mind that dies. The human skull is an exclusive VIP club, and it has a strictly enforced capacity limit. As an intensivist level nurse, your ultimate job isn't just treating the disease or hanging the antibiotics, it's playing bouncer at the door of the foramen magnum. Keep the pressure controlled, keep the swelling down, and keep the brain exactly where it belongs.